pleasure to join you for this international knowledge exchange, and I'm excited to be here and also to reconnect with my great friends and colleagues, Juan Carlos and Marco. So looking forward to the discussion. I'm going to start with just outlining the policy context in Scotland. I hope some of you will have visited our country. We are a little smaller than Catalonia, probably about 2/3 of your size. We have a mix of urban, island and rural communities, and just under 20% of our population are over the age of 65. Health and social care are fully devolved from the UK government, and we have had for very many years universal health coverage and more recently no co-payments for medicines. In 2002, 20 years ago, we introduced free personal social care for older people, and more recently that has been extended to younger people with dementia. There's a range of social care cash benefits for people with disability or for carers. And all of that is organised and delivered historically through 14 national health service local boards and 32 local government administrations, with the local government having a statutory responsibility for the delivery of social care. In addition, a very vibrant charity or third sector who have a very key role in providing social care alongside the independent sector. Our social care landscape is very complex. About 80% of personal social care is delivered by independent or charity providers, and only 20% delivered by the public sector. All of that is a small proportion of the real care that is provided by family unpaid carers, with about 800,000 of those in Scotland. Our reform journey started over a decade ago, when in 2011, just in the context of the economic crash, we had 4 pillars of public sector reform: a focus on prevention and early intervention, a commitment to develop the public sector workforce, including leadership in the public sector, a commitment to be more transparent in the way we monitor and report and publicly share performance information, including through the use of digital technology, and a commitment to greater integration of our public services and working together with communities to deliver better outcomes. Outcomes that matter to people and are based on understanding what's really important. And in Scotland, we have a body called the Health and Social Care Alliance, which is an umbrella organisation of lots of healthcare charities, and they amplify the voice of people with lived experience and hold us to account for what we deliver, and are a very powerful partner to co-design the way we take forward our health sector reforms. And they're very similar to the National Voices organisation in England that you may have heard about, that described for me one of the best definitions of integrated care. Care that is planned with people who work together to understand the needs of myself and my carer, and give me greater control, confidence, and deliver care that achieves my best outcomes and helps me to live my best life. That's what integrated care is really all about. We had some very early landmark legislation around personalisation in social care. And in 2013, the Self-Directed Support Scotland Act was introduced to give people more choice and control over how their social care was delivered. And there were 4 options. The first option could be that they got the cash as a direct payment and they employed their social care providers themselves directly. And some people employ personal assistants to provide their social care. The second option was a bit more conventional, where they direct who gets their funding and they allocate an organisation of their choice to provide their care. And the third one being the much more conventional one, that the local government, the council, continues to provide the support, with option 4 being some sort of mix of these, perhaps for different needs. I'll come back to that legislation later. It's a really good example that having progressive legislation is not enough to make change happen. Probably our big call to action around integrated care was population ageing. And using some very simple modelling, we understood that the red chart was the way our bed occupancy was for the population in 2007. And with predicted ageing, we were able to model that if we didn't change the way we looked after older people, we would have to build a new district general hospital every 3 years and open a new care home every month. And that was not affordable, it wasn't feasible, and it was certainly not the future that older people wanted. So that led to a programme called Reshaping Care for Older People that I was clinical lead for. And that programme kicked off in 2011 and was one of the first examples of the public sector reform. It was supported by a £300 million change fund. Sounds a lot of money, but over 4 years, not a huge amount. And it was only about 1% of the total health and social care budget for older people. But enough money to bring people to the table to have conversations about what they might do differently to use that funding. And there were a few simple rules, one of which was 20% of the funding had to be spent on supporting carers, caregivers, family caregivers, to have the information, advice and support to help them stay well. We already had a strategy and support for carers, and we knew that raising awareness of carers, involving carers in planning, supporting carers with information and advice and well-being and regular breaks were really important to help carers stay well, and a very significant preventative spend, investment and early intervention. The rest of that programme was really about shifting left across that slide, shifting investment and workforce away from institutional settings to more community-based, proactive, anticipatory care, and underpinned by some significant enablers like ICT, technology, and workforce development. Although that was describing a pathway of care, nowadays we understand that care is really an ecosystem of supports and services that should be wrapped around the individual, the family, and the local community. And it's how those supports and services relate to each other and interact with each other across health, social care, and community and voluntary sector. The next realisation in our journey was that it was not just about older people, It had to be about adults of all ages with multiple conditions, multi-morbidity. And some of the landmark publications from a group of primary care researchers who demonstrated the significant impact of deprivation on the age at which people experience multi-morbidity. They experience it 10 years younger in the more deprived communities. And they also experience the combination of physical and mental comorbidities. So that took us from a focus on aging and reshaping care for older people to understanding complexity. People with complex support needs, in terms of functional ability, people with complex conditions and multimorbidity, and also people with complex life circumstances, with addictions, dependency, and mental health issues, who often are frequent attenders at the emergency department. And that took us to a new paradigm where we had to move from a focus on hospital and episodic care to more continuous and coordinated and integrated health and social care. In 2014, there was legislation to mandate health and social care, not just to work together, but to be integrated in terms of governance arrangements. And the 32 local authorities were given a choice of two models. One chose a lead agency where the workforce transferred across from one organisation to another, but all others chose a model called a body corporate, where nobody moved their employment status, but there was an integrated chief officer, a single person who was jointly accountable to the health authority and to the local government. And that single accountable officer had oversight of an integrated budget and was supported by an integrated joint board whose job it was to plan and commission services for adults. In some areas, they also integrated children's services and family services as well as adult services. They were responsible for strategic planning for the health of the population, understanding the needs of the population. And this just shows the governance arrangement that the integrated joint board had with a lot of members drawn from the health authority, drawn from the locally elected council, but also with strong professional membership and membership of community organisations and local older people groups or disability groups who were part of the integrated joint board. The integrated budget was not just a nominal budget this time. You will recall that the Reshaping Care for Older People budget was 1% of the total spend. This time, about 2/3 of the health and social care spend on all adult care was devolved to the integrated authority to plan and commission the right balance of services. All community health care, all primary care funding, all adult social care funding was fully devolved. And importantly, a proportion of hospital budgets was also devolved. And that was important because it gave the integrated authority influence over hospital spend. And that influence helped lever some changes in pathways and models of care. They were responsible as an integrated authority for planning for population health, starting with understanding local needs, analysing the data so that they could target investment to the right parts of the system, the right community groups, and could work together across the whole system to improve outcomes for people. And we had 9 national health and wellbeing outcomes that each integrated authority had to show progress. Each of those 9 areas of outcomes are underpinned by metrics that they routinely record, and they are a mixture of numbers, activity, flow, percentages, and experience of care and support. Reporting progress on outcomes is only possible if you've got good data, and if you've got data that is integrated and shared across health and social care. In Scotland, we have a community health index as our single health identifier, and community, primary care and hospital services data is fully linked through that mechanism. We're in the process of seeding social care data with that community health indicator so that we can track not just the health journey, but also the social care journey and resource utilisation. We're getting better, but I still have a long way to go in making sense of social care data. We're now reporting on care at home data, data in care homes, telecare support, self-directed support, and also some areas are looking at resource utilisation for different functional abilities using the ION tool. Because of the impact of the COVID pandemic, we're getting more granular around our care home data, and there was a real-time reporting of care home data so that we could better target our healthcare support to the care homes during the pandemic. There is little point in having integrated governance unless you have integrated standards and joint inspection of health and social care. And so that was an important step in our journey. And you can see that the 5 main integrated care standards are framed from the point of view of the person who receives health or social care. And underpinning each of these 5 statements are a set of standards that are expected to be delivered, whether you're in a social care at home setting, a care home, or a community health care or hospital setting. A very important part of the journey has been workforce development. It's people that change lives, not legislation or policies. So we have had to develop the workforce through interprofessional education and cross-sector learning, and developing our enhanced integrated teams to understand how they can work better together, to understand what each other's disciplines delivers, and to respect and trust. And all of that takes time. Integration is a contact sport, not a spectator sport. And probably one of the significant changes that's been introduced is contractual in primary care with a new GP contract, which has moved GPs away from focusing on a lot of data recording around quality of chronic disease towards much more collaborative practice. And I've left the links to where you can read in a bit more detail about the change in contract. The collaborative practice has been supported by some national development programs, developing the extended primary care team to work in a sort of chronic care model. This is really very much built and framed around the Wagner's chronic care model, and supporting people to have the information and advice and support to self-manage their conditions. And we introduced a concept called realistic medicine, which is about supporting greater autonomy and empowerment. I think the word was used earlier, empowering the professionals to empower individuals to be the lead partner in their healthcare. That collaborative model is sometimes described as social prescribing. You might be familiar with that term, where you're using community supports to help people to stay well. You're signposting to the vast array of assets in local communities that help people to keep well, whether that be through neighbourhood groups, physical activity, support for nutrition, using faith communities. And many of these examples have mushroomed during the COVID pandemic. And I know that within Catalonia, you've had a similar experience of some community-led health and well-being supports. Compassionate communities, even in Scotland, I've heard of Compassionate Vic. So lots of similar examples. We have a very vibrant voluntary sector in Scotland, and it's important that we see the voluntary sector, the community sector, as an equal partner in our workforce. About 13 billion pounds per annum is the income of the third sector. That's about equivalent to the health and social care spend for adults. So it's a really important player for us to work smartly together. Some of the specific professional-led interventions that I would signpost to are the work that we've done on anticipatory care planning, thinking ahead, and I'm looking at Jordi, who's been doing some very similar work on using, risk prediction tools to identify people who are likely to experience a crisis or approach an end-of-life phase of their illness. Understanding what people's thresholds are, what's the ceiling of treatment that they want, and when it's appropriate to move towards a more supportive care approach. And sharing that information through key information summaries, electronic summaries that are automatically available for professionals in out-of-hours services or emergency services, so that they understand what that person's threshold was, what they wanted to happen. Was it care and support at home rather than being transferred for high dependency care? All of that needs to be enabled by digital solutions. And I look with great envy at the electronic health record and the ICT infrastructure that you have in Catalonia. We have ambitions in Scotland to have a very well-developed ICT infrastructure, but we're not there yet. But there is a very active technology-enabled care programme across government, working with housing as well as health and social care and independent and voluntary providers. It's absolutely critical that reablement, intermediate care and transitional care are central to your approach. This is an area of high impact and early win. And I'm not going to say much more about that because you have the experts in the room who are providing cutting edge intermediate care models in the community. It's important that we take time to reflect on what the data is telling us. And I'm really pleased that we have been recording data over the last decade and are able to show that despite the line showing what you would have expected based on population aging, we are not using the expected number of care home beds. We are not occupying the expected number of emergency bed days. And that difference between what was expected and what's actually been observed equates to 10,000 older people every day in Scotland being in their own bed and not in a care home bed and not in a hospital bed. That's a very powerful impact, which when you put some costs around it, are really significant costs avoided. When I look back at the 300 million change fund for 4 years, we have 3 or 4 times the return on investment now compared to that time-limited investment then. So we have certainly shifted the balance of care, but have we improved the experience of care? There is no point in shifting care to the community, but it's a very poor quality experience. So every 2 years, we have a national health and care experience survey where we're sampling patients and carers and asking what the care was like. And it's good to see progress in terms of access to care. But I think when you look at the coordination of care, we've still got much more to do to get that right at point of care. So let's be honest with ourselves and continue to strive to improve. Although I showed you the 10,000 older people that are not in hospital every day, not in a care home every day, you don't often focus on what you can't see. You focus on what you can see in front of you. So a lot of scrutiny and media focus is not on that 10,000, but it's on the 12, 13, 1,400 people that are still in hospital waiting to go home, even although that's often quite short waits for their social care package. And I think that's a huge challenge to get the media messages right. Clearly delayed transfers of care, delays in being discharged from hospital back to your own home is not a good thing at any age. It's a particularly bad thing for older people who are likely to defunction in hospital. But it has to be kept in perspective and compared to the situation that we could have had we not made the changes. And it's definitely clear that a lot of that further progress is being constrained by the inadequate investment that there has historically been in social care. And I think it's fair to say that the public and professional attitude to social care has not been equitable to healthcare. We stood on our doorsteps every Thursday night and clapped for our healthcare workers during the pandemic. It took weeks before we were also clapping for our social care workers, and weeks again where we were clapping for our wider public sector workforce. There is still a challenge in terms of parity of esteem with social care. We need to do more to improve the terms and conditions of workforce in social care. It's unethical that I can earn more in El Corte Inglés than I can as a home carer. Now, I don't know if that's the case in your country, but in my country, I can earn more in a supermarket than I can in social care work. We need to do more to develop the learning and career progression opportunities in social care. And we need to do more to really get personalisation at point of care, including better adoption of the promise of that self-directed support. So our public sector reform continues. Although we had the legislation in 2014, we are now looking at further reform of social care, seeing social care not as a cost, but as an investment to build better lives, better futures, better communities, and understand that investing in social care is community wealth building, because social care is a green industry and it's a local industry. Oh, sorry. I don't know if you can put that back. I'm sorry, I've flipped through. If you can put that back onto full screen for me. Thank you. So we're now consulting on a national care service. We have just introduced a new bill in Parliament to create a national care service and to make sure that that is truly accountable to people and based on human rights and best value. We're still in the early stages of parliamentary debate around that. There is a long way to go before we're clear about the detail of that legislation. Some of the early actions have been appointing a new minister who's responsible for mental well-being and social care. We already had joined up health and social care at government level. We had a cabinet secretary for health and social care, but we feel we need a ministerial voice who's strongly advocating for mental well-being and social care. There have already been some improvements in terms and conditions, but not enough. A full, fair wage has not yet been agreed. There is a social covenant steering group composed of people with lived experience of social care that is advising the minister. And as I say, the bill has been introduced in Parliament, as well as a healthcare framework to support adults living in care homes. Some of the specific proposals include national guidance on ethical commissioning for social care. Remember, I said 80% of social care is commissioned, not directly provided. And too often that has been through procurement, time and task limited procurement, rather than commissioning around outcomes that are important to people. Relational commissioning over time, rather than 1 year contracts. All of these are changes that we need to make. We need to improve our information sharing standards, not just across the statutory sector, but also extending to the independent and charity sector as well. And one of the other new introductions is something called Anne's Law, nothing to do with me, I'm afraid, but it's giving relatives the right to be with their loved one in a care home during times of pandemic, because the tragedy has been that relatives and families were locked out of care homes at great harm psychologically and emotionally to their loved ones and to families. So as we take forward this I won't say final, but further phase of reform, and we get greater debate about the specifics within a national care service, I'm mindful that we need to think beyond care to prevention and creating health and creating health equity. Because one of the shocking statistics in Scotland that has got worse rather than better is our shocking gap in healthy life expectancy across areas of our country and even within areas within our city. I know that in Glasgow, where I live, you can take a metro ride across the city and you can reduce your life expectancy by 14 years in the time that you cross the metro. So we have to do something that goes beyond the triple aim, beyond the quadruple aim, and the quintuple aim is providing better care, better quality, better outcomes, better experience, but in a way that creates health equity. I've been asked to think about what are some of our lessons, and I'm going to kind of leave that slide up for a little bit. Some of our lessons have been, I've been trying to describe as I've gone through the narrative. Engage and involve people. This is a contact sport, not a spectator sport. It cannot be done to you. You've got to co-design and touch hearts and minds with a combination of data and narrative stories. Empower and enable professionals to empower and enable the people that they support. Collaborate and coordinate efforts across all disciplines and across all sectors, and make sure that you pull mutually reinforcing policy and contractual levers at the right times to create the conditions for integrated care to flourish. See this as an improvement journey. Think about this as innovation and continuous improvement, not as a big bang. Test, be prepared to try things and fail, but be curious and learn from your mistakes and learn from others like ourselves in Scotland. We have a lot to learn from you as well. And reflect and learn. Some things will get worse rather than better, but be strong, be bold, and stick with it, because this is a marathon, not a sprint. I've sketched through our 10-year journey in, just over half an hour. If you want to read more detail, then our edition in the International Journal of Integrated Care's anniversary edition gives a lot more detail and references for our journey. And we described our journey around the 9 pillars that the International Foundation for Integrated Care developed as the pillars or building blocks of integrated care. And I hope that those pillars will be a bit of a compass for you in your work going forward. And please keep the conversation, keep the dialogue going. Come and visit. Marco and Juan Carlos have my contact details. One of my roles, no longer sitting in the government, but sitting in a sort of, think tank at arm's length. One of my roles is helping to coordinate study visits. So if you want to come and continue the dialogue, get in touch. And I hope that we can be a knowledge partner and help in buddying and twinning your ambitious journey. And I wish you every success.